Examination. Patient is conscious, oriented, moderately built and now no pallor, ictus, pedal edema, no generalized lymphadenopathy. Vitals pulse 80 beats per minute, BP 120, 70 millimeter. Systemic examination. Peritoneum soft, non-tender, non-distended, no organomegaly, CVS S1 STK, RS bilateral, normal vesicular ultrasounds, CNS, no focal neural deficit, skull and spine are normal. Coming to the local examination, external genitalia, ulceroproliferative growth, 6 cross 5 centimeter, present over the shaft of the penis.
You don't have pictures so that they can read it.
Yes, sir. Yes.
Picture, let them one of them.
Yes, sir. Yes.
That's what clinical examination. We read about what is it. Penis is in the midline. The 3 centimeter deletion. The ventral aspect of the penis. Wall in the shaft. Proximal. The distal shaft. Necrosis. Appears small. What else you see? The site. R6 looks over. Direction. One picture you can't make unless you see the shaft.
Induration.
Induration.
Duration. Inspector finding a fabric. Okay.
So ulceroproliferative 6 cross 5 centimeter over the shaft of the penis in the ventral aspect. Painless, irregular borders, induration present, not bleed on touch, penile edema present, false smelling discharge present. Base of the penis and scrotum not involved by the growth. Lymph nodes, right inguinal lymphadenopathy present, single mobile, 1 centimeter in size.
Will you do a correct examination?
So I would do correct.
Why?
Because causes the perineal body or any prosthetic.
Prostate. Of course, they say unless external iliac nodes are positive, you can feel the operator group on nodes, pre-cycle group on node, not in this case. But always, all urologists do a correct leg. Don't miss correct examination. Suppose there are huge external iliac nodes. There will be operator group on nodes can be felt by correct examination. Even Campbell here, pre-cycle nodes. Correct examination is much better. You can have additional malignant. We don't know what is that.
What do you want to do for this patient?
Do you have a differential diagnosis for this? Yes. I have no differential diagnosis, obvious carcinoma. Be bold here.
I'll do a basic parameters.
Yeah. Which biopsy? Under local or the anesthesia?
Probably anesthesia is not.
Please, modern era. Modern era. Don't tell local. Somebody does biopsy for you or me. No, give good anesthesia. Take good biopsy. You take a biopsy. You will examine your nose and the anesthesia. Better seen and anesthesia. You go and nose and you take a biopsy. You send it for histopathology. What do you look for?
Type of customer, what it is, what they use for the customer, the date, the depth, the cholesterol, they can tell us it's late.
It's not like they can tell. They have to tell. Okay. Guidelines says, yes, they have to report, especially about that these 16 months and long. Okay.
You should plead the examiner. Then how do you classify? Low risk, high risk. You lead the examiners here. Sometimes you lead one subject. You lead the examiner.
This notice is CIS, EA and D1, G1 will be notice. Then we get this to C1 and this will be E1, G3.
Based on that, we proceed with next phase. Suppose what is the biopsy for this?
Sir, squamous cell carcinoma.
And that's all.
Grade 2.
The lymphocyte infiltration, you have perineal infiltration. Must or no? Yes or no?
What do you want to do for the lymph nodes?
So clinically it is positive. Sir. So
I'm not
it is clinically positive. So it will be an N1 since right side single unilateral
Step by step. I was saying, what is the primary lesion?
So for the primary lesion,
You don't treat same lymph node same time. Give some time. You don't treat the same time. What do you do for this primary lesion?
so we'll see whether the induration, where till what extent the induration is involved, and based on that, if 2 centimeter margin is able to be kept, some we can keep, then we can go ahead with the margin.
You have seen the case. Duration going up to the
We
mid
total-
minute. Don't get trapped. Then I'll ask you what is indication of partial pinectomy. Partial pinectomy is 2 centimeter margin. If you have the pinna length more than partial pinectomy. Common partial pinectomy problem is recurrence. In this
Total,
patient,
total
total pinectomy
with having in the
When you are seeing this lesion, supposing you are seeing the patient and you palpate the lesion, can you give it clinical staging?
yes.
Hmm?
Yes.
Okay, supposing you are palpating thing, any other investigation you want for a clinical stage?
Ultrasound we
For
can
this patient.
ultrasound we can see
what are
Any other investigation? This is for
MRI.
yeah. So the role of MRI scan, the role of imaging studies in the case of someone may ask an examination, is prepared to answer that. Any role for imaging studies in non-palpable lymph? Yes. It does no. Well, yes.
high risk patient. If we see high risk patient, the non-palpable nodes, we should go ahead and
No, it's not.
we'll finish.
High risk.
We'll go step by step. What are you going to do for the lesion? You said total
total
pinectomy.
pinectomy.
Painless.
As I said, say if you have a dilemma in making a T staging, you have to go for MRI and not ultrasound. Present guideline says ultrasound is not that much efficient to diagnose a T stage. So go for a MRI. Okay, especially urethral involvement or corporal involvement. And for a previously operated inguinal surgery, you may need a imaging study.
You've done a total pinectomy with perineal absorption. And when do you look at the, how do you treat them? How many weeks, how many days you wait or weeks you wait? Apart from
one section. Like, even the superficial, is first one is superficial, medial, supermedial, and superficial and deep.
And deep. In superficial, approximately how many nodes do you expect? Suppose you do a superficial environment, approximately how many nodes do you expect? Superficial.
So
Yeah. Now, how do you?
so it is 5 groups.
Yes.
It
Yes.
is,
Is it important to know the groups?
yes.
Why?
So supermedial.
One of you answer. One of you. You want to answer?
Supermedial group.
How is this divided supermedial and
Based on the weight.
yeah. What attribute is?
So the
So all you can
supermedial
ask is the exam.
supermedial is superficial epigastric weight.
Yes.
Superolateral is superficial circumference. Inferiolateral is and
Okay, in general, based on saphenofemoral junction,
Why the supermedial node is important to you? Yeah. Is there any sentinel node that was the teaching? Is there any change about the concept of sentinel node? Let us say when we discuss about dynamic sentinel lymph node biopsy, do you go right to the supermedial group and then take a biopsy there, or do something else to find out sentinel lymph node?
The role of sentinel node biopsy at present.
So dynamic we
Is there any role of dynamic sentinel lymph node biopsy when you have palpable node?
We bold here. Now,
we don't have a problem.
A palpable node. Huh?
okay, in what patient you will do dynamic sentinel lymph node biopsy? Of course, in palpable node, there is no role.
So in non-palliative, there is chances of 20% of occurrence. So in those patients,
Why don't you go for imaging for those occult metastases, like FDG PET or CT, MRI?
sensitivity is less than 37%.
Even PET scan, it won't detect if it is less than 1 centimeter. So ideally, you have to go for a dynamic sentinel lymph node biopsy. Or one more thing, okay. So for which patient you go for a dynamic sentinel lymph node biopsy? Okay, lymph node negative patient, I am asking.
sentinel biopsy, now for this case, you have a node pattern. After surgery, node is present. How are you going to proceed with this case?
Take for 4 weeks of, after
Right side what you do, left side what you do.
after 4 weeks, we do.
இப்போ இப்போ இதுல எப்படி நீ வந்து அட்ஜஸ்ட் பண்ணுவ அட்ஜஸ்ட் பண்றது எப்படி போடுவ
FC node of sentinel node biopsy is all given up. What do you do? Will you do a block dissection or not? Right side, the nodes are palpable.
Obviously, I go with a modified.
Why? What sir told is
When you have that,
ஓகே
what surface is okay. Even now it is being practiced. Even I was practiced. But what is the guideline? Guideline tells you to wait. What is the guideline tells you to wait?
EA 22, 20, what the guidelines is. Before that, go for an FNAC. If you have a palpable node, just go for an FNAC. And the guidelines is the idea of so or waiting for 6 months, it will increase the chance of metastasis, which will worsen. Because once you get a lymph node, what is the survival? That prognosis will come to that. Once you get a metastasis, you don't need to wait.
The single most prognostic factor in CNS is
Metastasis. So
even though the lymph nodes is going to design your prognosis. Yeah.
Do not go the guideline, what is given textbook. Right side node, you go with what? Block dissection, yes or no? Yeah, node is palpable. What's it going to do? Process.
this The same thing you're going to face in exam. So you have to go according to the exam.
Only based on a
The
textbook
Campbell.
Campbell. Examiners got very different views. What's given in textbook Campbell, notes are palpable. Even FNSC, they say not much effective in case of
Nodes are
notes.
possible as per the Campbell. It says Ipsilateral will go with the deep and superficial. And if it comes as positive,
Go.
more than 2 lymph node is positive or extranodal extension is there, then we go with the conjunctival plus pelvic.
Yes, you are
Same.
correct. But when you do the ipsilateral lymph node dissection, you also do the contralateral superficial dissection.
Exactly. Next step.
That is what is.
This is mathematics. Yes.
Why should we do opposite side?
Because the drainage is bilateral
Crossover.
crossover with lymphatic nodes.
You have crossover pelvic lymph nodes. So you don't need to do a bilateral pelvic lymph node. You do ipsilateral. And if you go rightly, then if you have more than 2 nodes positive, or if there is a extranodal extension. That's the point if you are the
Yes, you're going, sorry. Going for surgery, fine. Do you want to do any other thing before proceeding to surgery for this patient? Not the primary, before, okay, lymph node, as I said, wait for 4 weeks before going for lymph node dissection. Still it is there. You want to do anything else?
So it is a high risk, so antibiotic therapy.
Okay, so 4 weeks over, after that. What's the chance of pelvic lymph node metastasis?
Chances 23%.
So you need to go for an imaging of abdomen as well as chest before proceeding to surgery. Yes or no?
Clinical positive, you can go ahead with 18 and
If clinically negative, you don't need to do a metastatic workup. If clinically positive, you have to go for an abdominal and pelvic imaging plus the chest imaging. Yes or no?
Absolutely. You understand this. If nodes are not palpable, there is no work for that. When a palpable lymph node, you have to do a imaging investigation. Don't get confused, okay? When there is a palpable, do imaging.
Presence of large iliac nodes. Then you will have chance, 30% chances in pelvic nodes. Then you can go.
Supposing it was the N3 node. What is the N3 node?
N3 node is more than multiple it is bilateral. Or it is node, or it's more than 4 centimeters.
Bilateral comes in N2.
A fixed node. Suppose you have a fixed node.
Then multiple bilateral, it's a fixed or pelvic node is N3.
Suppose you have a fixed node. Now, how do you go about this? You have this lesion there.
New adjuvant for without
Yes. So what neoadjuvant chemotherapy you will
paclitaxel, ifosfamide system.
you have to have is platinum and the taxane. Okay.
No, there is a situation. Forget about it. Always see a process, always they give in Campbell situations. Low risk, no notes. बात करनी है, बात नहीं करता.
Low risk patient, we will do a penectomy, then we can observe.
Follow. High risk, no notes.
Even in the high risk patient, we require for the lymph node sampling staging. So at least we need to do a superficial inguinal lymph node dissection. Bilateral.
What is bilateral superficial inguinal lymph node dissection? How it differentiates from radical inguinal lymphadenectomy?
In a radical, we will remove the radical the boundaries from anterior superior spine to the pubic tubercle. On the inferior range is a 15 centimeter from the pubic tubercle as well as 20 centimeter from the anterior superior spine. The superficial node and deep node as well as we will want to ligate that subvenous vein with the sartorius transposition was done on the radical. Superficial only we will want to remove the superficial modified. Modified we will remove
Superficial to
superficial
Facial.
facial.
Of fascia preserving.
Yes.
Okay, and then you don't like it, the,
Something
and you don't do a,
sartorius.
why this modifications are come?
Post-operative pedima lymphocyte.
And what is the most direct application of doing it? Sepsis.
Sepsis.
To know how to do a dynamic sentinel lymph node biopsy, the steps there. Then
What is sentinel node map? Where exactly is it? Given very clear cut node situated between. Sentinel node. What is sentinel? What is sentinel? What is sentinel? What is the meaning of sentinel?
no, it's guard,
God.
GAE guard, not for you. GUA.
What is the first sentinel node? Node situated between you describe it. Femoral vein. Between circumflex. Yeah, he told actually.
I told the situated between the junction of the superficial epigastric vein and your surface.
Definitely.
Intermediate. Okay, so how do you do it? Do you go and just sit there, go there and take the note from that place, or you do something? What is the procedure of doing it? Dynamic sentinel lymph, it's a short note for yours.
4 hours before we put give technician 99.
Where do you want?
Very,
Must have very tumor. Okay.
very tumor we give 0.4 of technician 99. Fourth, yeah. And then the type of,
That is there, but you must be able to write short notes. Exam short notes, then write short notes. Okay, as an extension to this previously, when we were this, there used to be some OD lag. What is OD lag? Someone may ask you what is OD lag? ODI-LAG. ODI-LAG. OD lag. OD lag, huh? Open direct inguinal lymph. Nowadays, some examples are studying their ask you. We talk about sentinel lymph node biopsy, some of them ask what OD lag. It must be different models. Those days, the lymph nodes management is very important when you talk about sales. Okay, you must know about peel, know about peel, right? Suppose they have to short notes, something to write about peel, you must know.
What is the,
You understand?
what is RAV? Still those things are in trial. So why they have brought all these things into, it's mainly to reduce the lymphatic complications, lymphedema.
So, and then in short, how the concept came initial days. See, where the lymph node drains first. They thought it drains first, goes to the sentinel node. We did a biopsy. No, it went into superficial inguinal nodes. Then they modified into superficial inguinal node into Catalonis block dissection. What is Catalonis block dissection? What all they remove nodes there? Because there some people felt instead of going directly into superficial, some metastasis goes into the deep inguinal node also at the level of femoral modified Catalonis block dissection. Again, they went a lot of controversy. Then they finally come to discussion. Nodes are not there. Go in high grade, you go for superficial block dissection because if it is positive, then you go for EU-angle block dissection. That's what is given. Anything new and newer in this? Suppose after some time, after a follow-up, you have a node on the opposite side, any other side. You are talking situation. Comes a fresh node comes one side. What are you going to do? Will you do a bilateral block dissection one side? after treating the primary cause, nodes you're on the follow-up. Suddenly a node appears.
One question is, how do you follow the patient after doing a partial penectomy and lymphodissection? How do you follow?
How do you follow?
What is the frequency you follow? Supposing you have a rectus on one side, you section only on that side, or you want to try on two?
Temple there is. Uh-huh. There's no crossover.
You have to go in this situation, it's not only lateral side, you want to research. Okay, please very clear about that. Recurrence, it is not never bad.
Is it after chemotherapy or straight away? Sir?
No, after the treatment, whatever treatment you are given, after your penectomy and lymph dissection,
Follow.
and adjuvant therapy, doing follow.
Follow-up and no nodes, other you, what is the best way of follow-up?
Clinical examination.
Clinical examination, not investigation, MRI, CT, only size, determinate size. Clinical examination is the most important process. What is role of chemotherapy?
Chemotherapy, the role is neoadjuvant chemotherapy, when there is the lateral fixed nodes more than 4 centimeters.
Where do you want to chemotherapy? Sorry, surgery is a treatment of choice for nodal pathology. Where do you want to give chemotherapy?
Reduce the bulk of it.
Bulk and
Make it resectable.
make it
Resectable.
So you're going to resect only in case patient who are going to respond to chemotherapy. Okay, what is the idea of doing a pelvic lymph node resection? How much curative it is?
Idea is to reduce the metastatic, tackle the micrometastasis.
It's only to prognosticate the disease. There is no rule of curative resection in pelvic lymphadenectomy. It's only to prognosticate. If pelvic lymph node is positive, what is the 5-year survival rate?
It's 5 to 20%.
It's around 30 to 35%.
You're talking about pelvic lymph dissection. So, how will you, what incision will you do? What incision do you prefer? How do you go about it?
Probably the BIRA will be a lower midline lateral, lower midline incision.
You want to combine.
Ilia inguinal and pelvic.
Combine both. Okay. Which that is when you have to go to inguinal and combine. It's a total section. It comes more than 2 or possible. Okay. See. You see that.
A safe incision or a Gibson extension.
Or you want to say what is called the lazy extension.
Lazy extension.
So in the first step, you don't go on cutting. The lazy extension. So you may not have assisted or done. You must know about
Then you should know the boundaries of pelvic lymph node. That's routine, right? Laterally genitofemoral, medially bladder, above is a bifurcation of common ilia, below is the inguinal, and posteriorly obturator.
Second question,
When
the operator knows the external iliac performance or internal iliac performance? Are you sure? Sir? The median most portion of the external iliac performance. Go and see and correct me if I'm wrong.
Yeah, it should be knowledge to correct. We should know
Okay.
more than examine.
This is the median most portion of the external. This question was asked by one of the examiners. Okay, and I went and saw, he was correct.
So this incisions, they'll ask routinely. Then idea of coming to modify to the variations, you should have a small incision, thick flap, stop dissecting lateral to femoral artery and below the fossa ovalis. So these are the things you should know.
Below what fascia? No, face subcutaneous, what are the layers there?
The capsule and the scarpa.
You have dissect below. Let's see, yeah, this is first. Below,
Below is the campus.
Okay, now supposing you are planning to do a total amputation of things. You want a total amputation of the penis. In this patient, you are proceeding for a total amputation of the penis. Sir, can you please tell me the steps? Steps of total amputation of penis.
So we'll give a elliptical incision over the.
First, you are from which college, sir? You? From CNC. Oh, okay. Then you must have seen and assisted also.
So we give a elliptical incision under spinal anesthesia is given. Patient in supine position.
Elliptical incision or we just call something else. So you can go for total amputation. Put elliptical incision. Where is the elliptical? Where do you put it?
So circumferential around the
Something else called bracket shape.
bracket.
Bracket. Can you say?
Yes.
Okay.
Patient is in a lithotic position. We put a tense bracket incision. Then we deepen and till the separation of the and ligation of the
What are two
dorsal
segments you encounter on the
suspensory ligament and the fundiform.
which comes first, which comes next?
This fundiform will come first, and then the
Are you sure?
no suspensory ligament
Yes.
will come first.
Yes.
Reach up to the
Yeah. When you
fundiform.
go to the fundiform, what structure you will be careful?
Dorsal.
Dorsal artery?
Or
Dorsal vein. Why? You must identify and ligate.
Ligate it. And
What can happen if you don't keep cutting and then you don't like it? What can happen?
it will retract and
Yeah,
then
we need to see it. Go and control that.
control your components.
Right. Good then.
And then we'll reach at the fundiform ligament. From fundiform.
That is an over.
And then separate the spongiosum and take the urethral margin and put a
When you start, when you do it, you start with this hemistatic incision and then go for amputation, or you start with something else. You always practice in your institution.
first do the
Or you first go to the perineum, take a bandage strap, separate the urethra, and then go for it.
so first we go with the complete the penectomy and then
Okay. Okay. Then,
mark
okay, fine.
use a flap next and
No,
then
no, you will not come. The Pura. What do you do? The Pura?
so through our pubic ischemic rami. We
Go
start
and
with
save it from the primary or
no sir, we use in that is in radical. In total we don't shape. Clamp it and take a closure of the corporal bed and after separation of the spongiosum and the urethral margin we have cut, will make a
then
urethrostomy.
you proceed with the perineum.
U-shaped flap will create.
Okay, right, good. What do you do to test this?
So we don't do oculectomy.
What is advantage of being able to test this? Or disadvantage of
After amputation of the this thing, the testosterone, so libido will be high, so patient will have bleeding out. So better, lot of people do oculectomy along with
what is
this.
disadvantage of being able to test this?
What is the oculectomy? Increase the libido of
So if
See
you
the
back
what?
test, it increases libido, and so he psychologically he has
yeah,
problem. So you go to what is the, I just want to know what is the, what
Hello.
is the problem.
we don't.
You don't do architecture. You need more.
Please tell, I don't know. See, it can be done anyway. Different people have different practices. Okay, only thing you must know, I want to say this, I want to say, what is disadvantage of being back test is? Because advantage, disadvantage.
Testosterone.
Andropause.
So
What is andropause?
Keeping the spot of 9 out there.
Very,
Every time he passes urine,
the chances of
he has to lift up his spot line. Why do you? So when this topic comes, the topic can go into andropause. So it's a bad argument.
You don't do more tests in value.
What about managing lymph nodes, the same setting or as I said, 4 weeks.
So after 4 weeks.
After 4 weeks.
Guidelines are guidelines. What to back to what best for. Very radical. Actually,
The rest of it,
Before we conclude, sir, one small doubt, sir. Sir, if we are having very small lesion on the gland, is partial penectomy the most minimal procedure for the CFS, or is there?
Case related, yes, give me situation. Come on and ask her, come and ask. Ask her, let them answer.
There are various benign preservation therapies which can be done for a small lesion.
Come, ask her, come. Don't ask me. No, he's asking very pertinent question. Not in this case. What are the minimally
Benign preservation therapies.
small.
Yes. Local treatments as well as invasive treatments.
Now you must ask, minimum small lesion in the glands means how big is the lesion? The involvement of the,
The location of the, yes, as well as the depth of the.
you must know that. Okay. And also,
Nodal stream.
that is the gland lesion itself. You take a biopsy. In biopsy, what does you will see?
The lymphovascular invasion.
Based on that, you will go. So there is no lymphocyte invasion. It is just limited to the skin surface, gland surface, not involved in corona surface. Then what are the meaning with this? You have to treat a lesion in the glands.
We have local treatments as well as invasive treatments and radiation. Local treatments include 5-4-erosion and the Micumod. And the invasive management includes glandsectomy or glands resurfacing with over a graft. And laser treatments include the NDR or CO2 laser, developing filtrate, as well as radiation also, brachy or
2 centimeter of canal.
wide.
Hold the field.
Will you do?
What's the connecting most disadvantage is recurrence.
Will you do most micrographic surgery? They'll ask.
Most it's basically it's not followed now. So it's basically a chemo surgery. We resect by layer in the tissue base and then send for ILC and then wait for the margin. It's done in stages. And it's not a single surgery until we resect until we get a negative, complete negative margin. And then if the margin diet is negative.
You know, wait to- not given it.
Yeah, it will be sometimes asked in your examination. Can also come as a short notes for you. It was for most micrographic chemosurgery.
Just to give a thing provide for fixation of tumor, the lesion, and after fixation, 24 hours after fixation of the lesion, it used to take a section and observe in the microscope till the negative margins are reached. This surgery used to take weeks to months, so it was over stages. So this was again taken with a frozen section rather than giving a zinc chloride fixation. And on for frozen section, still the surgeries went for a longer period rather than, but not more than.
Any conservative surgery, you can do it for a patient only after discussing everything with the patient, number one. Number two, patient should come for regular follow-up. Patient should be complained enough to come for follow-up. If not, you go for the highest dose.
Thank you, sir. One last question. Involvement of the urethra in CAP is what stage?
Can we do all this?
Thank you.
Thank you, thank the students.
Next, we call upon our beloved Professor Jagnesh sir, to be the examiner for the next case. Professor Ravi Sundar sir. Prakash sir. The candidates who has taken the lots for this session, kindly be on stage. Already the case has been allotted for 4 candidates, I believe.
A comparatively easy case for whoever wants to take and come and take this case. I think the candidates are already, right? If not, why don't you take this guy from SRMC did well yesterday? Please come up. And Tanmay, why don't you please?
I hand over the proceedings to our examiners.
So we come from SRMC Chennai. Tanmay from Prakash Medical College.
Kumar from Chennai.
Going to be very informal session. Very more of an interactive session.
Good morning, sir. A 50-year female came with the left loin pain, which is on and off since 2 months. The pain is in dull aching nature and non-radiating, and no history of fever and vomiting, no history of hematuria, pyuria, calciuria, and no history of obstructive erythritidis, and no history of loss of appetite or weight.
Who is the primary discussant now? Who is the primary discussant? We'll ask others also. One of you will be a primary discussant. Who wants to be the primary discussant? Just take it. See, it's just any of you can be a primary discussant. You will be. Your good name?
Asmal.
Welcome, Professor Prakash. Stanley. Right. You can be the primary discussant because they will be asking any of you questions. You can take the discussion forward. That's right. You just put your thoughts on this presentation.
The 50-year female patient complain of
Let me not repeat it. You have seen this.
Yes.
Just imagine you are sitting in the OPD and this patient is come to you. Just
so on the basis of this history, sir, my first probable diagnosis will be the renal calculus disease and renal calculus disease, sir, stone disease, sir. Second will be, sir, PUJ obstruction. Third one will be renal cystic disease. This is no history of fever and vomiting, sir. So no.
how do you want to proceed with the case? This is a clinical case.
I want to know about the past medical history, surgical history.
Known case of hypertension and treatment for 5 years. No other comorbid illness.
Any surgical history?
Sir, no surgical history.
One. Black general physical exam.
Sir, an examination conscious oriented and no pale and jaundice cyanosis clubbing, pedal edema and general lymphadenopathy and vitals are normal. An abdominal examination inspections, all quadrants move equally with respiration, no scars or dilated veins present, and palpation, no mass palpable, and superficial or deep palpation. Normal, no normal degenerate abdomen, no free fluid, and auscultation, normal bowel circle.
General physical examination is within normal limits, sir. So my probable diagnosis will be in same renal calculus disease. So first one will be the renal calculus disease. Second one is PUJ obstruction. Third one is renal cystic disease. And fourth one is malignancy. RCC.
I want to do urine examination and blood biochemistry, urine routine and urine culture.
Proteins, puzzles 1 to 2 FCD.
Yes. Urine culture,
Good culture, no good, no good.
urine function test and complete blood count.
As a complete that within normal limits, sir. The RFT also within normal limits.
So, sir, blood biochemistry and urine exams normal, sir. So I want to know about the ultrasound abdomen and pelvis with X-ray KUT.
It's ultrasound claim.
So right kidney seems normal, sir. And left side, sir, PCS dilated, pericardial system dilated with the maintained parenchyma and dilated calyces communicating with the PCS. And bladder seems normal.
So you saw that label, no? It has left HUN.
Yes.
What is it? What is HUN?
I do uterine proximal uterine.
Yeah, it's been marked as HUN. So now you have to open up your mind. You cannot fix to one diagnosis. Your initial diagnosis is stone or PUJ.
Yes.
Here it says HUN. Because also you're not seeing the ureter beyond. What is the fallacy of ultrasound in a
Yes, sir.
So what is the fallacy of ultrasound in diagnosing a PUJ obstruction? Is there any fallacy or you're okay with ultrasound?
We cannot make out the sort of uterine dilated.
Wait.
Because of the bowel state of the
Pardon?
bowel. Yes.
Because of the bowel interposes and you won't see the dilatation. That is one thing. Anything else? So that's a gray area. That's a gray area in the ultrasound where you cannot pick up. So you go for other image. The other thing, you've got a dilated system and you're not seeing the ureter. What else it could be? Considering it, I'm telling you it's a HUN. So what else you will think of?
Ureteric calculus, lower ureteric calculus.
Lower ureteric calculus. Okay. Without stone, anything else can give HUN.
Ureteric strictures, sir, it could be GUDV, sir.
Dilated system can be either obstructive or reflux. So if there's HUN, you can think of reflux. So that brings you the question, what is the association of VUR in a case of PUJ obstruction? VUR and PUJ obstruction. Is there any association? Have you seen VUR with PUJ? It is only empirical question we are throwing you. You know the case well and you are prepared. Just since it's written as HUN, I'm asking you more on VUR. Suppose there is a VUR, you can have a hydroelectrolysis.
That is common in pediatrics. Yes. Newborn. Yes. Or so I have discussed this before. We want to see what are the
Okay, you imagine this is a neonate, not an adult. You imagine this is a neonate. Physically, you want to have more.
how do you proceed. So to rule out the vesicular reflux, we have to do VCVG, sir.
We are saying it's a neonate. So just for your discussion.
So we have to stratify the risk P1, P2, P3, mild, more intermediate, and high risk on postnatal laser. And we have to see the 6 parameters in ultrasound. First one is epidiameter. Second one is renal parenchymal thickness, parenchymal appearance, ureter and bladder. It is all parameters are abnormal. Then we have to go further workup the VCUG and
It's a neonate. Neonate means within.
first we have to stabilize the child, sir. With active infection, then we have to treat and we have to drain the bladder with the high French IFT. Once the child gets stabilized, then we can plan the VCVG and BPP scan at 1 month of age.
Neonate.
And make this ideal. Make it ideal for.
PCG first or
Basically, you want to rule out what? You want to rule out
Use the obstruction.
ultimately the contact
Less than 20%.
Can you have a secondary PUJ obstruction in a gross B1? It's a grade 4 reflux. Can that give a PUJ obstruction? Just throw your thoughts on.
So if you get a PUJ obstruction, is it intrinsic or extrinsic? Gross grade 4 reflux. Can you get an obstruction at the PUJ level? Intrinsic. That is congenital.
No, it is seen in the context of a grade 4 VUR. That means there is
Dilated
gross
tortuous ureter.
reflux in ureter.
Because of kinking, sir.
Thinking and fibrous.
Very late stage,
Mostly
not
extrinsic.
very common. Late stage only you get. Otherwise, the coincident,
It will not.
as a coexisting condition, it's not much, only 0.5 to 1% only. Some studies.
So let's go back to the.
So you just proceed.
So now you have this, you mentioned that the cortex is normal. You expect the cortex to be normal thickness in the case of such a dilatation, cross dilatation.
36.
56.
Where do you measure the cortical?
Sir, interpol region, sir, in transverse colon of the ultrasound.
Report.
Midpole region.
You have to take 1 second to think.
No, there is a controversy. When we studied, it was sports.
At the pole.
Now the latest Campbell has says that it is
What is the
a
normal cortical thickness? Normal cortical thickness.
Sir, parenchymal thickness 15 mm, cortical thickness more than 7 mm.
Normal.
When you say thinned out,
So now what is
This is normal.
Sir, 7 mm, cortical thickness 7 mm, parenchymal.
Let's see this the interpole region. How much? Because you're not measuring here.
so could you just define what is cortical thickness? What is
Sir, parenchymal thickness from the capsule to the base of the pyramid,
okay?
and cortical thickness from capsule to the base of the pyramid.
So what is the importance of each? Why do you want to distinguish between cortical thickness and parenchymal thickness?
So cortical thickness in our cortex means cortical medullary defensive lost.
Yes.
And in parenchymal thickness, that piece is dilated only, cortex is maintained.
Cortex is maintained. So it doesn't occur in this kind of cases. Such gross dilatation. So you cannot comment that the cortex is normal,
Maintained, yeah.
not based on one picture. Yes. So don't comment on that.
In the case of PUJ obstruction, particularly when the patient is asymptomatic and it's unilateral hydronephrosis and the RFT is normal, no active infection, why do you want to treat the patient? Understand the question? RFT normal, no active infection, patient is asymptomatic. Why do you want to treat the patient? Do you want to treat the patient just because he's anxious or as a neurologist? I'm putting the question in a different way so that you will think.
We can put the person on follow-up, sir.
Incidentally detected PUJ obstruction.
Asymptomatic, incidental, no active UTA, RFT is normal, unilateral PUJ obstruction in a 50-year.
We have to intervene to prevent the further ipsilateral compromise of the renal function and to decrease the incidence of the renal calculus disease and active.
Can you tell me how the renal compromise happens? Just in 1 minute, you have to tell us. What is the sequence of events following a PUJ obstruction? Sequence of events. I'm going into the pathophysiology.
Pathophysiology of obstruction.
What happens in a PUJ obstruction? Where is the pathology?
At the level of PUJ.
Okay, what happens at the PUJ?
Sir, PUJ narrowing because of the spiral musculature replaced by the longitudinal muscle fiber. aerosol have tissue, and maybe because of decreased density of the
See, pre-existing, there is a longitudinal layer and a circular.
Yes.
Apart from the adventitia, lamina propria. What happens in a feature? Is there anything else? It's just, there is a collagen interposition between them that causes an intrinsic obstruction. My question is the sequence of events. There is a pH obstruction. What is the sequence of events? What happens?
increased intrapelvic pressure.
Okay, then
Lead to
you just tell what all happens. We want to know why the renal deterioration happens. That's why you're asking this. You're right, intrapelvic pressure increases. Then what happens?
that, because of high intrapelvic pressure, that parenchyma will
What is the
Anyone else want to answer this? Anyone of you wants to answer this?
That will lead to increased hydrostatic pressure.
Exactly. Where?
The glomulus,
In the
tubules?
There is a hydrostatic pressure increase in the tubules. Then next.
because that tubular function will get deranged.
Okay.
Following that, the glomerular function also is lost.
Okay. Before that, you have missed one step. There will be a slight reduction in the RBF. Because of this pressure, there will be a reduction in the RBF, lead to a lower GFR. That is how the renal deterioration starts off. It's a cascade. You should know this. What are the 2-3 postulates which create the future? I mean, which create the renal deterioration? There are 2-3 postulates. It's more the pathophysiology. Some examiner will ask you. That's why I'm asking. Otherwise, straight away, PUJ obstruction, treatment, everything. You started off right, then what happens? There is a increase in decrease in RBF and a drop in GFR. Then there is some amount of renal deterioration happening. How it happens? That's what we have. Some amount of fibrosis happens, and there is also some ROS, reactive oxygen generation, free radical, all these things. So you just read about it. They will ask you. Okay, you proceed.
What do you want to do now?
So next, I would like to proceed with CT urogram. With mainly.
Why do you want CT urogram and not an IVU?
So the CT urogram, the thing is, patient will not require any preparation like as we require in IVU. And the thing is, the perinephric events also will be seen properly.
What additional information you will get in the CT urogram?
The perinephric events will be seen better, sir. And any crossing vessel also can be seen. And one more thing is the ureter will be well delineated in CT, sir.
Crossing vessel on a CT urogram. Just think and answer. I have never seen a CT urogram crossing vessel.
It has to be triphasic CT.
But you see how it is. You won't see the vessel, but you'll see something else. You see here, something like a negative shadow on the PUJ, something like crossing. You meant that only.
Yes, sir. Because
Okay, suppose you want to see the crossing vessel, what you can add?
triphasic CT we have to do.
Exactly.
RTL phase.
Fine. Then CT urogram, you can document, as you said, renal, extra-renal, vascular causes, intrinsic causes, extrinsic causes. Everything can be picked up. Okay.
You have a urogram picture also.
Sir, this is the coronal delayed imaging. On the right kidney shows normal in size, shape, position, and the uptake of the contrast is prompt on the right side with contrast excision is normal on the right side, and the ureter is draining contrast normally. On the left side, there is a gross hydronephrosis with pooling of the contrast, which is noted on the lower level, sir. And parenchymal thickness appears to be thinned out, sir, but it is little Little thickness is seen, sir. Yes, panel thickness looks maintained, yes, sir.
What is that thing you're seeing?
There is a layering of the contrast which is seen. On the right side, the layering of the contrast.
Right. Left side.
Left side, yes.
First pictures, the lower pole. What are those?
Contrast, yes. So on the no, sir, like most one is seen.
Why is that? What is that? Why?
It's because the obstruction, the held up of the clusters proximal to the PVJ. Sir. And the layering of the contrast also is seen on the lower pole side. And there is no prompt draining of the contrast seen on the left side, sir.
What is the use of degrade fill?
It shows us the contrast draining across the ureter, whether it is complete obstruction or partial obstruction.
The PUJ, is it a complete obstruction?
It's a partial obstruction, sir. Not a complete anatomical obstruction, it's a partial obstruction which is seen.
What is your inference?
Sir, is left pelvic junction obstruction, sir. Yes. Looks like extrarenal pelvis. No, sir, no training. No, sir.
You can see the contrast filling the pelvis, but it's not draining beyond the pelvis. You rely only on delayed image or something. What did you say? You said something. Prone. Okay. How it helps? Useful or not?
Useful, sir.
Definitely useful. How? How it helps to see the drainage. It makes the PUJ more dependent. That's all. Earlier days, in our student days, they were giving Lasix urogram. They used to do a IBU, then they used to give Lasix. Then it was given a weight, diuretic urogram. It was called. They don't do it anymore. Why? What we found, some of those diuretic renograms in a high-grade obstruction caused a fornical rupture. So they stopped doing it.
That's the
And then
reason why you don't give license even for
Stone disease.
another historical thing is they use the bands. Those days the radiologists used compression bands to accentuate the obstruction. That again can cause a, just for a historical. So here the unit you see in one film. You have to see. Huh? Okay, still in case you are not sure, your colleague says, no, sir, this doesn't look like PUJ. I don't think it's, then what you do? Then what you do?
To confirm obstruction, I would like to do a DDP adenogram.
DTP.
confirm. You mean to say you're still not, if you're not happy with this picture, you're not satisfied that it's a huge obstruction.
Looks like PUJ is a partial obstruction.
You have made a diagnosis of PUJ based on CT.
Yes.
Why do you want it removed?
to know the baseline GFR, sir, and it also helps us for the follow-up also, and to know the differential function quantified also.
Renogram. So in that film, that comment anything on this?
You use to connect point value.
There's no writing of the contrast.
You saw the right PUJ level, something like that you will see, and there is a result process. Exactly that. Sometimes we have seen in our practice, when we required one PUJ, the patient came back with a PUJ obstruction on the contralateral side after a few months or years. And then we found there was a PUJ, it was evolving. What percentage of viral PUJ?
2 to 5%.
Fine, you proceed with that. Renogram, who's going to rate the renogram? So in this case, you'll do a diuretic renogram, isn't it? That's what you want to do. When do you give the diuretic?
So yeah, there's 3 different kind of protocols which is followed.
In this case, you
Yeah,
always
please.
start pertaining to this.
Yeah, please
You have
start.
seen the Eurogram, CT Eurogram.
At 20 minutes after giving the IV contrast. 20 minutes, F plus 20.
Are they given like that?
22 minutes.
What is the advantage of F plus 15 or F minus 15? How do you decide? You said you will give it after the isotope.
Yes, sir.
What about F minus 15? Which cases you will do?
Periodic usually F plus 0. At the time of giving the IV contrast, periodic also is given.
Generally, nowadays, we are giving only at 0.
Only at 0. You are not giving after.
There's no plus 15. Unless situation warrants it.
Which situation you need?
Patient having history of CKD, like low output. Orally culture, and it is a time activity curve.
Okay, you read it.
Curves are there. The curves are staying there.
What are those images called? These plates, what are they called?
Time activity curve.
No, not the plates. What are they called? Images. That's centigrams.
Centigrade.
And the curves are called as O'Reilly curves. You read them.
So the first image curve show the perfusion phase.
There are 3 curves, no?
Yes, sir.
One is in blue, one is in pink, one is in dotted line. What is each? One is right PT, one is left PT.
Yeah, there's aortic trace.
Only one aortic.
To see from the aorta, like what time it takes for the perfusion to reach the both the kidneys to know that. So it's almost like almost parallel to the aortic trace. So within because the perfusion phase, the images are taken at 1 image per second, sir. So just within 3-4 seconds after the aortic trace, the perfusion is seen in both the kidneys, sir. It is perfusion looks normal.
Among these plates.
The lower one, sir, the function curve.
Not the curve, the films. That is the pudding of it. Which is the most valuable film? That the laser is placed out. That is saying.
The bottommost, the last one is the best one.
Generally, the post wide one. Last one. That will give you a lot of information. What do you infer?
On the left side, there is a pooling of the contrast which is seen, sir. Like there is delayed excision and pooling of the contrast which is seen on the left side. Stasis.
Which means what?
So it means like the contrast excision into the ureter, it's delayed on that side, on the left side.
Suppose the post-void you see less contrast. Anything else? Here you are seeing more contrast. Yes. Any other possibilities?
Post wording as vesicle trick. That
But here it's more of stasis. You are thinking in terms of PUJ. What about the GFR and which parameter will be very valuable to decide on a PUJ abstraction?
So TR and GF.
What is the TR? So it's showing the cost.
So,
into the perfusion on the left side. We are talking about that, no?
yes, sir.
Just see, you have to see that also. What is the perfusion on the left side? Compared to the right side, there is
Marginally delayed.
So that is another clue for you. Then uptake.
Uptake also is lesser on the left side. So
GFR.
GFR is
Yes,
lesser on the left side.
Other important one.
And the TF, I think it is not reached on the left side. So TF is
Not achieved.
Not attained.
Not attained. Okay. So what is TF? What do you mean by TF?
TF is the time for the 50% of the radio cases to reach beyond the period.
Yes, exactly. Offline of
6 hours.
Okay. So now, how to proceed?
What is the problem with the scan? Service in a case of kidney which is you suspect to be non-functional. Like you say, there's no contrast. It's totally unsuspected. But DTPA will, if you do DTPA, shows 40%, 35%.
It overestimates the functions.
You have to be a little careful.
The poorly functioning kidney, the surface area will be more.
Yeah, the
Surprisingly,
background activity.
yeah.
Because with cooling, you will get more active.
The patient and his relatives will be happy to read that, but actually you have to tell them that it's more. It's not the actual uptake. Analysis.
That is what's in CKD patient, the background activity will be more with DDPS compared to MAC3.
What are the problems for doing DTPA in children or MAC3 children?
You always prefer MAC3 children.
Why?
In kidneys.
So which is the best thing for children? Ethylene. Why? What is the mechanism of action of ethylene glycol and MAC3?
Totally tubular signature.
MAC3 is the 90% protein bound, and it will restrict via tubular secretion.
But
Doesn't depend on the GFR.
easy. The GFR is less than 30. What is the ideal size? GFR is below 30.
Yes.
What will TTP do it? GFR less than 32. You always prefer. Yeah. And very long.
For the exam, you should know everything about O'Reilly curves. You should be able to draw those curves and discuss them in detail.
The MAC3 in a pediatric age, how it helps in the context of users. The specific advantage of doing a MAC3 over DTP. So only investigation which helps you to distinguish multicystic dysplasia from a PUJ obstruction. The distinct thing. What about follow-up? You have done a PUJ repair. Suppose you have done a PUJ repair. In the follow-up, which investigation is ideal?
The DTPA 6 months.
Actually, DMSC is said to be more ideal. Anyway, refer that. We proceed.
On the basis of these investigations, left PUJ of the full time. Prepare the position for alpha.
So
56-year-old patient. Extraordinary. Your plan of action.
We were more able to go to the
Extra large extrarenal pelvis, it's better to go with the Anderson Hines dismembered pelvis.
what is the prognosis?
Large extrarenal pelvis, then chances of the recovery of the person will be more.
What are the prognostic factors? What are the prognostic factors?
So pre-operatively, the pericardial thickness, extrarenal and CFR.
What are the prognostic factors? These whereas particle thickness, then renal. Creatinine, renal parameters.
What are the indications for doing an RGP?
So an RGP in this case.
You are planning to do laparoscopically.
You are planning to do what surgery you are planning?
Open dismembered pelvis.
Open on lap of 30. Then you do a retrograde pyelogram in this case. That is all. What was done originally earlier days in our case?
So initially days the first.
No, during the 90s, what investigation used to be done? It was still RGP or something else. Another investigation which much forgotten nowadays. It's called as a bulb ureter. You go back and read about it. Right. So in this case, you'll do an RGP. If at all, yes. If you say yes, you tell the reasons. Only. What about you? Why? You justify your answer. Why? You will do RGP. Why?
First to know the site of that actually.
And your incision. Okay. Then anything else? Only that one. The thing is to confirm the level of obstruction. That is definite. What other advantage you will gain by doing an RGP? You won't be in for surprises. If you do a RGP in this case, you won't be in. There are a rare instance when even a senior person had to do for an open pyeloplasty, and then he found that the ureter was dilated right up to the lower end, and then he had to do another incision at the lower end. These things have happened earlier days. Nowadays we have imaging, better tools, but still you don't lose anything by doing an RGP. You won't burn your fingers. You can see whether it's what is the level of obstruction. You can see whether it's a single ureter or double ureter. What is a ureteric insertion? And as you said, planning the incision. So many things. Many we have even seen giant renal pelvis going down. Not this case, going up down up to the pelvis also. You won't be in for surprises in rollout. And is there anything? Sometimes you can have a PUC obstruction. Apart from that, you can have a narrowing in the proximal ureter. So many things. Definitely, an RGP is useful. You just coexist with the DO. Surgery will prefer. I only asked an exam this question. PUJ with PUR. But you should know what is the grade. Then only you can answer this. Then only you can answer this question. You got a PUJ obstruction like this, and you got a grade 1, grade 2 VUR. What will you do?
Pyeloplasty will deal with the obstructions.
Obstruction first. Grade 1, grade 2 VUR. Like this. Grade 5.
With low grade viewer first pyeloplasty.
We have crossed the time limit.
Just go with the different surgeries.
5 more minutes. They say 5 more.
Different surgeries which you know for. What are the types of surgeries? Quickly you tell us, and what are the indications for each?
Dismembered. One is police.
Okay, okay. Police viral plastic.
What are the principles in doing a pyroclastic? Very often question is that it's going to
Funnel shaped. Relation. Mucosa to mucosa anastomosis, water type, tension peak, and dependent.
With the internal drainage. With the internal drainage.
So in the same city, what are the indications for doing an ultrasound?
It is a single redo.
Yes.
And when you think that the anastomosis is under tension.
Okay.
You'll do it.
Okay. Okay.
What is salvage pyroplastic? Yes, salvage pyroplastic. You mean by last year I shot.
Any fail after failed pyroclastic. Say the technique. Can do pyroclastic we are able to do. We can do ureterocalicostomy.
Before that, can you revise the anastomosis? Can you revise the anastomosis? It's very, very difficult. Easy because it's everything is stuck. Next time you go and know, because it's an anterior incision. It's stuck. Still, you can try to redo. If you are unable to approximate, what are the options? You said ureterocalicostomy. Anything else? Endopylotomy. Yeah, of course. Endopylotomy can be done for a pyroplastic failure. Anything else? In open surgery itself, or laparoscopy, anything else you can apart from calicostry. So many ways to bridge the gap. No? Those days, ureteric loss used to be a question. Ureteric loss. What is so many flap procedures? Flap procedures. What are the procedures? Cardinal spiral flap, calf divert, capsular flap. All these things you should just tell. Please, if you're on that. You didn't tell.
Intubated Davis principle.
Okay, you got a fuse obstruction with the intrarenal pelvis, and there is a crossing vessel. Do a pyroplasty. There any special technique?
The name of this technique.
What do you do? Apart from what you have mentioned, what do you know? That's your stuff.
Yes.
What is that? Can you give it to him? Just explain Hellstrom. Hellstrom. Just tell us about Hellstrom.
The vessel is crossing.
So the Hellstrom, they do a dismembering or non-dismembering. Is the first question. Non-dismembering. Now you have. That's a clue for you. What do you want? What do you achieve by that? What is the full name? So Hellstrom's vascular relocation. Again, the answer is that relocation. What are you relocating?
So the anastomosis is done anterior to the vessel.
You're talking about Hellstrom is described as a non-dismembering. So what are really you are relocating the causing vessel high up. It goes high up so that it doesn't impinge your PVG. That's all. But how will you fix it? You are relocating it, again it will fall out. You have to fix it there. How will you fix it? You hitch the vessel, if you put a tie on the vessel, what will happen? Again, there's no, anyway, none of us may have done the procedure. It's been described. Maybe rare instance we may have done. More of academic interest.
Thank you.
Thank you. Thank you.
Next, we invite our beloved Professor Mayappan sir, to be the examiner for the next case. And Professor Sudhakar sir, I request Saravanan sir to invite our faculty. I hand over the proceedings to our examiner.
All of you. It's nice to see back my as a student, as a professor, now as a retired faculty for taking exam, mock exam. Who is going to discuss it? You're also that. Okay.
Veritas PRS sir to kindly join, please.
Please get it. You're from MMC.
A 25 years old male presented with complaints of overstream of urine for the past 2 months, along with straining to void for past. No history of hesitancy, intermittency, and retention. No history of frequency, urgency, and nocturia. No dysuria, burning micturition. No fever, vomiting, loin pain. No history of decreased urine output. No comorbid illness. He had a history of folic catheterization 6 months back for RTA, left lower limb, both bone fracture, and he was on catheter for 2 weeks. In his family history, no family members have similar complaints, and he has no history of addiction, mixed diet.
New to see, no issue of addiction. What do you mean by that?
Non-smoker and non-alcoholic.
So you are giving it in a single word. No issue. First time seeing. Okay.
Sir,
With this history and all. What is here?
Sir, a 23-year-old male, sir, presented with a 2 months history of avoiding LUTs, sir, poor stream and straining to void, sir, and no other positive histories. And all, the patient had previous trauma for which police catheterization was done 6 months back, sir, and he was on a catheter for 2 weeks.
What is your DD in this stage?
So, my first DD would be a stricture urethra, sir.
Very strictly urethra.
So the patient had a previous history of trauma and he was catheterized for a long 2 weeks.
Yes, catheterization was uneven.
So I want to ask that history, sir.
That's very important. Why?
Sir, due to some iatrogenically induced stricture or following catheterization, any inflammatory strictures, to differentiate that, you have to ask that history, sir. Was that easily catheterized? Any history of bleeding per urethra during catheterization?
That is important.
Traumatic catheterization is one of the causes.
Stricture. There was also possibilities that is associated with some pelvic fracture. Now we have to think about some posterior urethral stenosis or EFUT. Catheterization.
Possibly. All those. Okay.
Then what else? You go stricture urethra. differential diagnosis was this period.
Urethral calculus.
Students will be able to avoid, but it's still be able to avoid the prostate urethral.
So if it obstructs the lumen, it will be
different. Still you can avoid.
Can also be a cause of prostatitis following long catheterization.
There was no history of the dysuria.
Dysuria, there is no frequency dysuria. And the possibility of so neurogenic bladder can be kept as a last.
Neurogenic bladder. What are the points to say it's a
So we have
able to avoid midstream. So main complaint the ankle. There is history of trauma. Typically neurogenic element diagnosis. Anything else you have? Maybe what are the causes of security? Go back to the
So most commonly it is idiopathic 30%, then hydrogenic 30%, followed by inflammatory or infectious strictures, then post-trauma surgery.
post-trauma. Inflammatory. All these things are
Infective cause.
Same.
Sexually transmitted transmission.
What are the common organisms?
So usually gonococcal thread discussing stricture and non-gonococcal like chlamydia, ureaplasma, like those organisms can also non-gonococcal strictures can produce.
That is all you do. Anything else? Previous instrumentation.
Previous instrumentation.
Irradiation.
So external urethral meatus, the pollen circumcision. And
what is it called? Circumcision causing meatus. Approximately. What is it?
PX. That may be zero difference.
Any other reason can produce? Lichen.
Lichen sclerosis.
So these are the commonest causes because the patient is a young patient. Okay. Right. How to proceed?
So I would like to general examination following local examinations, genital examination as well as DRE, and also some vocal neurological examination to rule out any cause of neurogenic bladder.
Okay. Why DRE?
So first to assess the anal tones in cases to rule out any neurogenic bladder.
You need to say the neurogenic element would be there in this case.
So just to rule out that possible.
Your thinking or your approach towards the patient attached to the symptoms.
So I would like to examine the genitalia.
Here, what will you look for? Direct examination. Anatomy, sir. What would you look for in prostate?
Prostate, sir.
Yes. What would you say?
The grade of the prostate, nodularity present or not.
How would it appear?
Tenderness,
How would it appear in the structure? Prostate.
Firm and contract. So firm and contracted.
You should have flat mass. Then if it is, can you diagnose prostatic abscess by doing PSA?
Yes, sir, it may be a boggy and
Is that a
prostate.
possibility in this patient?
Prostatitis and prostate can also be following infections.
What else do you look in the local examination?
So I would like to see if any phimosis is present or not. External little meatus if it is narrow or then any evidence of hypospadiac meatus is present or not. Then palpation, I would like to see if any induration is palpable. Induration and any evidence of fistula or abscess formation in the periapital region.
When you have abscess formation or stroke,
And then when there's a distal obstruction following it and superadded infection, there will be distal formations.
long standing.
Wrong standing.
Long standing. What's the contrast cause? What will you do? Very chronic.
Tuberculosis. Stricture is narrowing of the anterior lateral lumens. It may involve either the epithelium or the spongiosum. Scarring of the tissues happens. Fixed narrowing of the anterior, resulting in
Anatomical narrowing.
fixed anatomical narrowing of the anterior.
The lumen will not accommodate the instrument without disruption of
Mucous.
mucus membrane. That is the definition. Any instrumentation will get disrupted. This is- That's it. It's not possible. Very careful to numerical treatment. Discuss the exam. Discuss the point. That's all. How do you this? How do you proceed?
So there's a classification, divine sort of classifications. There are 5 grades in first grade is mucosal prolapse. Second one is iris constriction. Third one is minimal spongiofibrosis. Fourth one is full thickness spongiofibrosis. Fifth one is if it is associated with the fistula formation.
What is the best investigation to see for the spongy?
Solo erythro.
Withdraw?
Solo erythro.
What is the frequency of ProBio?
7.59.
What's the pathophysiology in such a
So whenever there is meatal narrowing, there will be high pressure voiding. It causes intravasation into the glands of Leydig, which causes the formation of microabscesses, which heals by fibrosis and causes scarring.
Scarring of
Mucosa as well as
Spongiofibrosis.
spongiofibrosis.
How will you proceed?
So I would like to know about I'll do a urine investigation to and culture sensitivity to find out any infection. And if anything is there, I'll first treat it and then I'll proceed with the retrograde erythrogram, sir. Sir, Euroflow, sir. Euroflow and post-viral distal urine.
What are the salient features of the case of security?
So there is a box-shaped pattern on Euroflow, sir, in which the Qmax will be equal to the Q average.
What would be the usual?
Less than 10 and 6 height.
This box there, then what It's so fine.
Reduce peak and long providing fixed
Where to? Describe a normal Euro graph.
normal is a bell-shaped.
Bell shaped. Is it continuous or just like this? Is it a continuous pattern or bell shaped continuous pattern?
Continuous.
When do you reach the when does it reach the Q max or peak?
1/3 of
The entire tracing. Rapid descent.
post-vital residual using ultrasound.
What would you look for in ultrasound?
In ultrasound, I look for the bladder thickness, bladder wall thickness, and any internal echoes suggestive of any infection or something like that, and also concomitant any stones or any transformations.
Upper tract
Status.
PVR continuation. Urine routine, urine
Urine culture system. So then I would like to go with the imaging of retrograde.
Or ascending.
Ascending.
Either way you can. Then ask for. What is the prerequisite before doing AEG?
Prerequisite. So any infection should be.
Before taking a pill, AEG, what is he is asking prerequisites? Because infection has to be ruled out. We'll take a plain
Scout films.
Scout. Wait.
So, first, to rule out any calculus present in the urethra or not, and also to rule out any bony abnormalities.
Any bony abnormalities or any evidence of
Fractures.
Then following that, you have to subject the patient for contrast.
So, patient in lateral positions. With the lower leg flexed and the upper leg extended, I would inject contrast urographin.
Lateral or oblique position?
Oblique position.
Oblique, what are the positions of the lower leg?
So the lower leg should be flexed at the knees.
Correct.
Upper leg should be straight,
extended with the oblique position.
Oblique position.
Wait.
So the urethra should be stretched parallel to the long axis of the femur. Sir. So by attaching a piece of cos pieces.
Okay. Where? Attaching the cos piece where? Unless otherwise you have done it in the radiology department, you may not know. You can't expect the radiologist to do it every time. As a urologist, you should be able to. Are you doing it?
Yes, sir. So after that, we'll inject contrast. So
how will you stretch the still line there?
So around the corona, we'll tie up a gauze piece and stretch it against.
You just around the corona, you put a gauze piece and gently give a traction so that your fingers will not come into the picture. Then, what else you do?
Be parallel to the thigh.
Parallel to the femur long.
Before injecting the contrast, what you do? Straight away you inject the contrast.
You ask anything to the patient to be done.
These things are all important. Sometimes some examiner may stick on to this. Just to find out whether the candidate has done the procedure.
What will happen if the patient faints? You keep pushing the contrast.
The extraction.
So how can you avoid that? Anything else you do? In jelly.
Xylocaine.
Yeah. Then, how will you inject the contrast?
Sir, I will dilute the contrast, sir, with the normal saline 2:1 dilution. Then 20 ml.
That's okay. Directly you will put the syringe in.
Either I will put a 8 or 10 French police and inflate the balloon at the level of Gladys and inject. Or if it is not available, I'll use infant breathing tubes.
Infant breathing tube, you cannot insinuate the whole urethra. The tip probably at the level of
The meatus is very much narrow. Even I cannot insert IFT. What will you insert?
Butterfly can
Influm.
read this.
So this is AUG showing long segment strictures involving the distal bulbar and proximal penile urethra.
Long segment stricture.
Multiple.
Wait.
So
where is the stricture?
Distal bulbar proximal penile.
Proximal penile instrument. Be clear.
How many do you see then? How many strictures do you think?
One stricture I could.
Then why do you want to say long segment stricture?
There is irregular narrowing of that urethra.
Why is that irregular contour of the urethra is seen?
Maybe because of supratic infection.
Urethritis. Associated urethritis there, but there is a stricture. What can you describe the stricture? Anybody?
The stricture involving the distal bulbar urethra. So two strictures I'm able to make out. So two narrowings at the distal bulbar stricture. Beyond that, the bulbar urethra, the proximal bulbar appears dilated.
Two narrowings over there. One narrowing.
Other is mild.
Yeah.
It is negotiable. Sit down. The stricture, as you rightly said, in the distal bulbar.
Yes, sir.
Typical site, anatomical site. Between Penoscrotal junction, penoscrotal junction. It is beyond the bulb. The stricture is beyond the bulb. There is a history of catheterization. It's quite common. Why it is common in penoscrotal junction?
Because during
What
catheterization,
are the site of strictures in case of instrumentation?
most common is the penobulbar junction, sir. And then-
Penobulbar.
The bulbar
When
urethra.
you will get TURP stricture, post TURP.
TURP, the most common site will be the proximal bulbus, followed by the fossa navicularis and then the anterior.
No. Post TURP stricture, where which site is common? Three places are there.
Yes, sir.
What are they?
Fossa
All
navicularis.
you people are very much interested in bulb. What are the anatomical sites?
Bulbar membrane. Fossa navicularis. and-
Penoscrotal junction. But two. That is the commonest place. Post TURP. Either monopolar or bipolar. In which condition the stricture is common? Monopolar or bipolar? Good. Okay. Penoscrotal junction. Then? Good. That's it. Here, there is history of catheterization. That is instrumentation. So there is a stricture. What is the nature of the stricture? Whether it is annular or is annular? What could be the length of the stricture?
Looks like a short segment, sir, but urethritis extends.
That is a different. Why all these parameters are important?
Planning the.
Correct. The site, the location, the length, the depth, all these parameters are important regarding the management of the stricture. Here, is in the penoscrotal junction or in the, as you see, it is a distal one. And the length of the stricture, is it more than 2 centimeters or less than 2?
Less than 2 centimeters.
Less than 2 centimeters.
Associated with the pan-urethritis.
So this is a finding and your inference. What other investigations you do?
To assess the degree of spondyloarthritis and do a sonography.
Good. How will you classify?
Spondyloarthritis is less than 1/3 of lumen, 1/3 to 2/3, and more than 2/3 restricting the lumen. Calamitous things.
Mild, moderate, and severe. And if the stricture is more than 2.5 centimeters, again, mild and severe. 5 types of. Why it is important?
Whether to go for like mainframe anastomosis or a substitution with or an endoscopic procedure.
This is anterior to stricture or posterior?
Anterior.
You go for any buccal mucus or substitute plasty or you try for anything. Which gives best result? Either endoscopic or open procedure.
Open procedures. Sir. Endoscopic procedures can be done the bulbar urethra whenever there is a short segment less than 1.5 stricture without any spongiofibrosis of the
Post-inflammatory.
post-inflammatory. So substitution will be better.
There is no place for
Endoscopic.
But we as a urologist, we always opt for wait.
Technically convenient.
Technically easy for convenient. The results are equivocal in case of open procedure. It's okay. So any other investigation you opt for stricture apart from the age. Of course, you told ultrasonography.
So MRI can be done in complex strictures or in case of PFE management, recurrent strictures.
Because there is a history of trauma.
From
MRI and delineate the fracture. What sections you look for in MRI? Axial or coronal sections will look for posterior.
Posterior.
With sagittal section. Anterior. So MRA, not for routine cases, only for
complex
stitches or when you suspect or
PSC.
So what is going to be a line of sight?
So you do a substitution erythroplasty, sir.
Just now you told that it's less than 2 centimeters. Why substitution?
It's the inflammatory stricture and actual length of narrowing may be underestimated with an RGUs. And
any other method by which you can estimate the length of the stricture? 5 minutes.
As a 10 minutes.
Okay. Any other method by which you can assess the length of the stricture apart from
MRI, so
why MRI for this case? Anybody?
Scopy.
Good. Scopy.
Erythroscopy.
How can you do that? How will you assess by doing erythroscopy? What instrument you use and how will you assess?
Usually use a small caliber scope. So we usually use a ureteroscope around 6-7.5. We use.
Okay.
We assess the caliber of the urethra. We assess the narrowing part. We assess the mucosa. Obviously, whether it is pale or pink. Any pale with the loss of
length of the stricture.
Length of the stricture depends. We assess. We can.
As you rightly said, small caliber ureteroscopes can be used. Fine. How will you assess the length of this? Because this is deceptive.
Yes. So if I'm able to put a guide wire via the ureteroscope into the bladder, and if I'm able to put a guide wire and then if possible, like the uretery catheter over it and measure the length of the stricture.
Is it so? Anybody? You will be able to pass ureteroscope beyond the stricture, go to the proximal, then you withdraw. While withdrawing, you have to measure length of. You understand? What is your, so you want to say substitution is that is your, anybody?
So young men, sir, 25-year men, I discuss with the patient, sir. I tell him that whether he has completed his family or not, I want to ask.
What is finishing
sexual function? I have to.
What is?
Sexual function. Obviously.
Still, we not finish our family. You are talking about 25-year-old.
I just explaining about the pros and cons of the open procedure and endoscopic procedure, sir. The endoscopic procedure chance of recurrence is very high, sir. Especially in an inflammatory stricture, we'll underestimate the length of the stricture by this only RG. So the even after DBIU, the chance of failures and the chance of recurrence is very high, sir. Comparatively,
Post-inflammatory scarring and fibrosis common. So what is your line of management?
So for this patient, I would advise him the best recovery from his problem would be BMG urethroplasty.
How will you put this answer in a nice way regarding your man?
Sir, the modality of treatment for him which addresses his complaints and with the least possibility of any failures or recurrence rate would be an open open procedure involving BMG urethroplasty.
See, since the patient is in pain, in order to avoid recurrence, they go for it's a post-inflammatory procedure. They go for a definitive procedure like substitution. So I prefer a substitution. Suppose the examiner asks you why you don't want to do internal all these things. Can you try end-to-end plus?
Sir, this is.
The stricture seems to be short.
The stricture seems to be short, sir, but the mucosal irregularities are seen. So intraoperatively, if you see, the diseased urethra may be more than what we have seen.
Exactly. The disease process may have extensive involvement, what we see in the age.
Both proximally and distally also the disease process may be more, sir. So also it's in the pinobulbar junction also. So if we want to excise that segment, we have to resect more than almost 2.5 centimeter, which may result in cardi or contraction, fibrosis or erection problems. Yes, the cardi. Yes.
Cardi will be there.
Yes. So
in order to avoid all these,
I won't prefer an excision
because patient is a young patient. So you have to give almost trying to give a permanent cure from this age. That should be right.
Where all can you take the graft?
Sir, most commonly we take from the buccal mucosal graft, sir.
In case his oral hygiene is very poor.
Oral hygiene, if the buccal mucosa is not good, we'll take from the lingual mucosal graft, sir.
What precaution you will take in case of buccal? What precaution you will do in case of lingual?
So in buccal mucosal graft, we should worry about the stencils left and then we'll take it. So in lingual graft, we should mark the Warthin's set and also the lingual nerve. So to make sure we are not disturbing both and then mark the site of harvest.
Advantages of taking harvesting buccal mucosa.
Advantage is that it has got a panlaminar plexus, so the uptake is very good, and then it has exposed to a wet environment. It is resistant to infections, easy to harvest, and so it is easy to handle also. So it's always a better graft cell because it is in a wet environment. It's easily suitable for reconstruction of the urethra.
Where else can you take graft?
Apart from this.
Lingual, then
Those are there. Anything else? That
small intestine. In this case, I will prefer a dorsal only, sir. It's in the pinobulbar junction, so the amount of spongious tissue ventrally will be very less. So I prefer a dorsal and then tilt it over the corpora and then
it goes by whose name? Dorsal only.
Dorsal only, Arbagis. Asopa's modification is open ventrally and then open the dorsal inlay and then the graft of the dorsal inlay procedure.
What is quilting?
So quilting is where we fix the graft to the beds, usually done over the triangular ligament and the corporal bodies, so that the graft gets a better vascular bed for its vascular supply, and it also helps.
Prevents hematoma seroma. Graft doesn't take up collection. What is imbibition?
Imbibition is cell swelling. The graft is usually a stage of imbibition occurs within the first 24 to 48 hours, whereby it imbibes without the vasculature, the new vessels forming. Before that itself, the cells will absorb the nutrients from the surrounding beds.
Inosculation. What is inosculation?
Inosculation is the inosculation revascularization of your staples after 48 hours.
Network capillary the vascular network starts. Inosculation.
Thank you. Thanks for the opportunity.
Thank you very much, sir. In fact, we are privileged to have Professor Anand Meyyappan sir with us because he was the only person who was the USA secretary as well as the USA president from Tamil Nadu. Thank you very much. So, because you youngsters may not be knowing the legacy of urology. So, yes, thank you. Before we go into the next session, we are waiting for Dr. Raghvan to join us. He is on the way in just 5 minutes. We have a few interesting X-rays for you. Maybe one of you can discuss, and faculty here can also discuss for few suggestions. Dheeraj, yeah.
Oh, very good. As HOD.
HOD வந்து பெரியசாமி சார் கேஎம்சி
ஓ ஆமா ஆமா ரெண்டும் உண்டு.
As Dr. Satish is getting the, yeah, Satish, no, let's get the CT picture. Before we go into the next picture, which Satish is getting ready, any small feedback from your side, like how this program is going on, or do you want any changes in this program? Because we are thinking that why can't we go ahead and have this program on a regular basis if this is going to be the response from postgraduates? Anybody?
Dr. Ganesh from Sri Ramchandra Medical College. It was a great opportunity, and I think this program should continue further and the same way, 2-day program. And the best thing about this program is all from Chennai and South India, we are all participating, and all the examiners from South India, we are getting to know what questions and how the things will be expected in exams. I think it's better we'll have at least 1 month ahead before the exam instead of 15 days. That's the only thing we can notify. Thank you.
Thank you, Parth. Dheeraj, what are we seeing actually in this image? Can you just describe it?
Sir, here I can see two CT. One is the axial.
Let's come to the low one. Let's come to the low one.
I can see a large heterogeneous mass in the.
Okay, I'll tell you that's the liver. Don't worry about it.
Sir, and the left kidney seems to be enhancing well, sir.
Left kidney seems to be enhancing well. Then,
And,
what about the right kidney?
right kidney, I'm not able to appreciate.
You're not able to appreciate the right kidney.
Yes, sir.
Okay, fine. So, what is your diagnosis?
Sir,
You've seen both the images.
yes, sir.
Same.
That I'm not sure. So in this,
You ask.
Same patient.
I would like to see even more cuts, sir, in this patient.
No, first of all, you ask. These two are the same patient.
Same patient.
Then you tell us what's the idea. Anything positive for you? What is missing here? First image.
Okay, sir. Not able to see the parenchyma on the pelvis clearly, sir.
You are telling that the left side kidney is highly enhancing.
Yes, sir.
You are not made any comment on the right side. First which side you are able to see?
Right. I'm not sure if there is any pelvic.
Right side, we told you that's the liver.
Yes, sir. No, sir. In the previous image, sir, in the axial cut, I'm not able to see.
What are you seeing?
What are you seeing? Just any enhancing thing?
In the midline, there is some enhancement, sir. Contrast enhancement. I'm not sure what phase of contrast it is.
What do you think the dog is? What is the dog?
Could be the kidney, the pelvic kidney, sir, with some enhancing component, or it could be the delayed phase wherein the. No, sir. That could be the delayed phase where the contrast is getting excreted, sir, into the collecting system. If I can. It's ectopic kidney in the renal. The right kidney is ectopic, sir. With these two images, I can say that the right kidney is ectopic and it is in the midline, sir. I would like to see even more delayed images to final.
Put all together, come to a conclusion and tell. What is the expression? Please. Put all together and tell the final version of your.
Is it? It is not on the right kidney is in the midline, sir.
So what is the final impression?
The right pelvic kidney. But
normal,
I'm
normal right pelvic.
The parenchyma I'm not able, is not very enhancing.
Something more. Something more. Is the normal position?
Ectopic kidney service.
Okay, sir. Aberrant vasculatures will be there. PUJ obstruction also can be there, sir. Yes, sir.
So, left kidney is enlarged or left kidney is not?
Left kidney is enhancing well, sir.
Enlarged, is it enlarged? If it's enlarged, why?
And what is the reason?
All that you have to tell. Why? What is it?
Sir, compensatory hypertrophy of the kidney can be there, sir. That case, if the other kidney is relatively less functioning. Yes.
So if you see this picture, as I was saying, you're thinking that is a pelvic kidney on the right side, which is much lower down, in which case there should not be a compensatory hypertrophy.
Yes.
So what is compensatory hypertrophy?
Sir, when there is a unilateral agenesis or one kidney is not, the function of the contralateral kidney goes down, the kidney goes for a compensatory hypertrophy.
Good, in which case the size of the kidney increases or does it increase?
It increases.
How much size it can increase max?
10 to 15%.
So usually around 1.5 times increase in size of the opposite kidney. And what actually increases in a compensatory hypertrophy?
What is the cause for the compensatory hypertrophy?
Sir, there will be more glomerular.
More what?
Praveen?
More or increased size? Or anybody wants to take? Anybody wants to answer this question?
Magadev? 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 Praveen will come.
Yeah, just 2 minutes because we will go to the next CD and then we'll go to the next session.
But the cause is mainly due to growth factors, mainly insulin-like growth factor.
TGF beta.
Usually IGF-1. No, more than that, in a clinical examination, what we require from you is what actually increases in the compensatory hypertrophy. If you have the word more,
Is it the number of nephrons increasing? Or what?
size of what increases? Size of the proximal tubule and interstitial. Both. Okay. Now you see this CT picture. You see this CT picture. Okay. There is a different CT picture. Now you see the TP here. You can use this pocket. Adhiraj, shall we take someone else? Okay. Yeah, please. Another guy from Apollo, please. Now we have another CT. This again shows a single kidney. See where the compensatory hypertrophy or there is no compensatory hypertrophy in this. How do you measure compensatory hypertrophy in a CT? One is the size, other one is vertebral bodies. How many vertebral bodies is the usual span of the kidney?
Normal.
Normal.
3 vertebrae.
Okay. Around a 2.5 to 3 vertebral bodies. The process 3.5 vertebral bodies usually say it is a compensatory hypertrophy. Here is a situation where we have a compensatory hypertrophy of the kidney. Okay, I'll tell you one clinical situation. This patient went in for a hernia surgery, bilateral hernia surgery, without being evaluated for the urethra, which should not have been done. This is done elsewhere. When they tried to catheterize the patient on table, they were not able to catheterize the patient. The catheter was going in comfortably, but when they tried to distend the balloon hardly distended 2 to 3 ml. No urine flowing. Wash given, nothing coming out. What is your likely diagnosis? One kidney is absent.
Jenner syndrome.
Fantastic. Fantastic. We got the answer from someone. I don't know who gave the answer from behind. Good, Ma. Your name? From? Ramchandra. Good. So I'll go down and show the pelvic pictures. So this is the case of a Jenner syndrome. You can see the dilated seminal vesicle on the same side. So just keep this in mind. You will have an unilateral kidney, difficulty in catheterization. Think in terms of Jenner syndrome. It is not that it is not very uncommon. It is present 1 in 1,500 cases. Okay, fine, good. I know Raghavan sir has come, so I think we'll go ahead with the next session. May I request Raghavan sir to kindly come on the stage for the next session. Request Professor K. Saravanan sir, our former HOD of Madras Medical College, to kindly come on stage for the next session. Professor Thiruvarul was very much here. Yeah, Professor Thiruvarul will also join the team for the next session.
This exam, okay, not an exam. So don't think quite very abnormally. Think straightforward. Answers are straightforward. The expectation is that you have to be a safe practicing physician in the community. That is the expectation. We are not expecting geniuses here. We want safe people who don't do gross mistakes. Is it okay?
A 60 years old male, former occupation, presented complaints of hematuria for past 3 days, which is total, gross, painless, associated with amorphous clots. History of dysuria present, no frequency, urgency, and nocturia, no history of weak stream, straining, hesitancy, and intermittency, no pyuria and calciuria, no fever and vomiting, no trauma, no loss of weight, and loss of appetite. His past history is a newly detected diabetic patient.
So, what is What is your inference from this?
So, a 60 years old male farmer presenting with gross painless hematuria. Along with that, he is having lower urinary tract symptoms like dysuria, no other obstructive or irritative LUTs, and there is no other significant history along with this. So, with this symptoms, differential will be might be some urothelial malignancy, lower tract or upper tract, or might be renal cell carcinoma or stone disease, might be cycle calculus.
I also think in terms of prostate related cause, even though there's no LUTs, which patient has dysuria, and both benign and malignant prostate have a significant incidence of hematuria.
Is dysuria and painlessness the same? Are we contradicting ourselves?
Yes, we are contradicting dysuria is there.
So if there is dysuria, what are the other differential diagnosis? Other than,
Inflammatory UTI, cystitis.
why would you have a 60-year-old male having inflammatory disease?
It may be related to bladder outlet obstruction, leading to recurrent UTI. Or else in vesical calculus associated.
So please, the expectation is that when dysuria has been given to you, what other condition, in addition to what has been discussed, which will present with hematuria and dysuria, which is related to malignancy?
So GUTB patients can present. Then
I asked for a malignancy. Thank you. GUTB is an.
In case of C prostate.
CAS. Carcinoma. Excellent. You think any benign?
Stone disease. Any benign bladder mass, like inverted papilloma. Urinary tract infection, cystitis. Interstitial cystitis. Hemorrhagic cystitis. Cystic or glandularis.
He is a newly detected diabetic, no hypertension, no history of hypertension, seizure, thyroid disorder, or tuberculosis, no history of surgeries in the past, no history of instrumentation or trauma. In his personal history, no history of drug allergies, mixed diet. He is a chronic smoker for past 15 years, 1 pack per day, not an alcoholic. No history of malignancies in the family.
What history of malignancies in the family will present like this?
We look for endometrial ovarian.
The other point is that I know we have a tendency to give a lot of DD. Please stick to the point in discussion, because this is not a theory exam, this is a practical exam. So, he says no history of malignancies in the family. Okay, and then you have a patient who has a painless hematuria or mild dysuria and hematuria. What malignancies can present this way in family history? What urological malignancies have a family history?
Upper tract urothelial.
What is the incidence of upper tract urothelial carcinoma with familial history in a male? Meaning, what is the risk of a son or a daughter to get an upper tract PCC because the dad has it? So RCC, what is the risk of RCC in the family? .52. What is the age incidence?
1 decade earlier than the usual presentation.
What is the normal presentation of RCC?
Normal presentation from 5th to 6th decades.
forthrightly, but it can be one decade. Okay, especially the translocation RCCs can be. What other urological malignancy has a family history?
CA prostate.
On examination, patient is conscious, oriented, afebrile, no pallor, acyanotic, no clubbing, no generalized lymphadenopathy, no pedal edema, stable vitals. On abdominal examination, on inspection, all quadrants move equally with respiration, no scar or sinuses, and no dilated veins, no palpable mass, percussion, normal resonant abdomen, no free fluid, normal bowel sounds present. On examining the genitalia, external meatus adequate, prepuce normal, glans shaft normal, bilateral testis and scrotum normal. Rectal examination, anal tone normal, mucosa normal, grade 1 prostate which is firm, smooth, non-tender and non-nodular. Systemic examination normal.
Sorry, did I miss a DRE there? But no. So we start from this side. So what is your inference? What is that you want to do next?
So
From the history, what is that you want to tell? 60-year-old
farmer, sir, who's having a gross painless hematuria and
who is a chronic smoker. No other so on examination, sir.
Recently detected that diabetes. Do you want to express anything from that?
Oral hypoglycemic drugs, any drugs used, pioglitazone, history of so one of the etiology for CA bladder additional sarcasm, one of the etiologies hypoglycemic drugs like pioglitazone. Pioglitazone causes. Now, how many years of usage of pioglitazone? He has been, they said recently diagnosed.
Recently diagnosed.
How many years of pioglitazone usage can cause? 3 years, 3 to 5. Study which came in year 2009 changed the practice of the pioglitazone for dental use. What other condition can present with hematuria? What other condition can sir ask for a particular thing saying that he stressed on diabetes? So diabetes, hematuria, what other condition can present that? Prostatitis. The questions we are asking are very similar to what you've seen in the ones. Not that we are asking of input. Can be a cystitis or prostatitis?
Melanitis can be.
Melanitis can cause papillary necrosis.
Out of this diabetes initially present in the one reason description with the high blood sugar levels, papillary necrosis, fungal, particularly candida, aspergillus.
What sir has been asking for some time. So what we'll start from this side now. With this clinical finding, what is that you want to do next? What is that running in your mind? What are the investigations you're going to ask?
According to the history and examination, our differential diagnosis will be urothelial malignancy of the bladder, or renal cell carcinoma, or upper tract urothelial malignancy. So we have to rule out things. So we have to start with the urine routine, culture, cytology, USG, KUB we have to do, and blood normal blood workup, urea creatinine. So after following that, see further.
Will you ask for something else in addition to what you said?
Population profile, history of taking any anti-platelet drugs, any history of any trauma, instrumentation, all those things. Yeah.
Any particular test? PSA also,
Serum
age
PSA.
is 60-year-old male. So he has an ultrasound scan. Your good name? Tanmay. Tanmay, you read that.
So it is the ultrasound scan of both kidneys and bladder, which we can see right kidney appears to be normal in size, with right side with validation of the pelvic alveolar system and ureter also visible. And, similarly, left side there's dilation of the calyces and the pelvis, so there's bilateral hydroureteronephrosis, and in the bladder, there appears to be a mucosal irregularity at the region of the left posterior and the right posterior side, two mucosal irregularities of heterogeneous equations.
Where is the ureter in this picture? Are you seeing it or am I imagining it? Definitely hydronephrosis is there. You said hydroureteronephrosis. I thought you had the magic eye to see the ureter as well. Stay with what you're seeing, yeah? Okay.
Describe the lesions in the bladder.
The two lesions are seen, which are located on the posterior aspect of the bladder on the left and right side. They are irregular in shape with the base of the lesion appears to be hyperechoic, with the contour of the bladder appears to be slightly altered, but I won't comment on that because it's a dynamic.
What is next? Any other investigation? One before.
X-ray KUB, bilateral kidney chillouts looking normal. And the bony is looking normal. No any radio bed shadows.
Next slide. What are your comments on? Urine protein, able to see RBCs, which is 4 to 5 per hyperpil, suggestive of hematuria, microscopic hematuria. What is the normal RBC count in urine? What are the things that you find in a urine routine? What are the parameters you measure in a urine? Urine routine, we see in the pH, osmolarity, any presence of WBC CAS, RBCs, presence of RBCs, any pulses. How many pulses are positive? 3 to 5. 3 to 5 is also pulsal. RBC greater than 3 is considered as hematuria.
Grade 5.
We can measure more than 3 RBCs per high power field.
So any RBC is considered positive in majority of the labs. So it changes with the lab. Majority of the labs will choose to say that any RBC found in the urine is considered positive, and more than 5 pulses are considered positive in a 5 urine. Any comments?
smile elevation of the creatinine, sir, 1.4, which is a borderline, sir.
What else is borderline?
RBS is also 70 to 110 is a bit. Sodium.
Sodium, potassium, creatinine,
All the-
RBS, urea, everything is borderline. What does it mean?
It could be secondary to an obstruction, as we saw there's bilateral hydroelectric process, so that would signify that it is impacting the renal function, leading to this electric.
The word that is expected is to say that
This
Can it be dehydration?
possibly so, but there was no sign of that in the examination.
Before we go to the CT scan, yeah, you want to answer? What are the imaging investigations that are required in a patient with macroscopic? Or what is the current terminology that is used for
Visible hematuria.
visible hematuria? So what are the investigations, imaging investigation required for a visible hematuria?
Contrast and CT, sir, with the delayed images.
Why contrast enhanced? Why not without contrast? Why not CTKB plain?
In plain, sir, we can miss. We will not be able to delineate the ureter, pelvis, ureter, and we will not be able to delineate if any masses that are arising from the bladder wall. All those things will not be very clear in the plain CT, sir. But
I'll ask the question differently. What is the role of the plain CT? What is the role of the contrast CT? That you're asking for a contrast enhancing.
yes,
Can I just do a contrast? My friend says, no, sir, I'll give you one dose. There is so much of energy is wasted. I'll give you one dose of contrast and take a film at 20 minutes. Is it okay?
no, sir, multiple films we need.
Why?
So starting from
What
the
is that you're seeing in each film?
starting from the initial this thing, sir, we need to see the corticomedullary phase. We need to see in the
What is the role of plain CT?
CT.
Why do you need a plain CT? Let us save money. Let's do one shot.
What do you expect in a plain CT? And the creatinine is 1.4.
Yeah. Our next question will come is how will you prepare the patient for a contrast CT? Two questions are to be done.
Firstly, in the plain CT, sir, we'll be able to appreciate the validation of the pelvic system, any presence of any calcified.
How will you assess the character of the system? I'll put the question back in. What is the role of a plain CT?
Enhancement of the
These are not enough lines. So, poor lines cannot be given.
So the word that is expected is to say that plain CT is the baseline to compare the next level of series. Number one. Number two, the plain CT also tells us about the stones or calculi in the urinary tract. Number three, or phlebolytes, calculi. For us to understand these things, you need the plain CT. Thirdly, it also helps you to understand the bone window. Nowadays, we are almost replaced every bone scan with just a CT. By just changing the setting in the CT, you will get the bone windows, which will tell us about the bone spread of any malignancy. Yeah. Now the contrast CT is done. So you start. What are the phases of the contrast CT and what is the role of each phase?
Arterial phase, corticomedullary phase, and excretory phase, sir. Arterial phase tells about the the supply of the kidney, sir. We will see the contrast in the vessels, how the how the kidney is perfused.
Everybody gets it.
We see the arterial supply to the kidney and then any enhancement in the arterial phase.
Enhancement of what?
If any tumor or lesion is there, then we can see enhancement in arterial phase that we can compare with the plane.
What is the role of the corticometric?
The corticometric phase will delineate firstly the renal uptake, whether the functioning of the parenchymal functioning can be seen in that. Along with that, in the bladder, during that phase, if there is a mass or adhesion, that enhancement can be appreciated during that phase. Also, your lymph nodes and all the other soft tissue enhancement will be.
So then nephrogenic phase, we'll be able to appreciate urographic phase, sir. Any mass lesion in the pelvis or in the ureter, we will be able to appreciate better. Any then later delayed phase, we will be able to see about the masses in the bladder, sir.
Sir asked a question. Creatinine is 1.4. How will you prepare the patient for it? Creatinine is 1.4.
Mildly elevated only, sir. We'll properly hydrate the patient before and yes, and
Who is going to read this?
Before that, why do you want to do a contrast CT? You've got ultrasound picture, and why do you want to do
sir, for the T and end staging of the mass, sir, we need to look any perivesical infiltration fat standing is there or not, and the extent of the mass, and involvement of any lymph nodes are there or not, and along with the bladder, any concomitant upper tract mass, anything is there or not.
In this case, particularly, there was hydroureter nephrosis, so it's definitely to look for any other lesions and whether there's extracycle extension.
Second is staging. Other is other tumors, like the tumor. So you got to first define the mass, how is it, whether it updates the contrast or not, enhancement is that. All these things you can see only in the contrast. After that, you can see the staging. Where it involves, whether it's locally advanced, other parts you can see. This is the purpose of doing contrast, triple phase contrast.
This is a plain film of plain CT scan film of abdominal pelvis. The soft tissues and the bone windows appear to be normal in these films. The right kidney appears to be enlarged in comparison to the left kidney with hydronephrosis with mild dilatation of the ureter as well is appreciated. Left kidney it's slightly small in size, and there is dilatation of the ureter and the pelvis going visible up to the distal.
Only one film or that?
The bladder cuts, it is the bladder is only partially filled. There appears to be a hyperdense lesion along the posterior aspect, along the base of the bladder. And the distalmost part of the ureters are also visibly dilated in those cuts. And they appear, the lesion appears to be involving the ureter complexes. The contour appears to be distorted on the posterior aspect with the minimal fat stranding noticed in the first.
Those two structures. Possibly, whether we can see on the delay.
So pressure is 30.
And delay will get done.
What is below the? Why is the catheter sitting on the top? Should be at the bottom, right? Why is it sitting on the top?
Most probably the mass is
Mass is in the lower.
lots on top of that.
What you are seeing above the mass is the clouds. That's why the catheter is anti. This quickly finish. Go to move on.
Contrast enhanced CT of abdomen and pelvis. Here we can see bilateral perfusion of the kidneys appears to be normal. There appears to be left-sided hydroureteral nephrosis.
This is what phase?
What phase?
This is the corticomedullary phase. Along with that, in the bladder, we are able to see in the left posterior lateral wall, there appears to be an irregular mass arising from the left posterior lateral wall, and there is irregularity in the right posterior lateral wall as well. Presence of clots and dilatation of both the ureters. No.
Seems to be at least some pararectal.
Yes, sir. This is histogram phase. This we are able to appreciate a broad-based left posterior lateral wall. So we are rising from the posterior wall of the bladder and extending to the left and the right lateral wall as well. So much periocycle fat stranding is present, and dilated ureters are also visible.
Is there a contrast in the left ureter?
No, sir. There is no contrast in the left ureter. Only right ureter contrast we can see. So multifocal broad-based growth with a huge tumor burden.
What is the even stage of the big volume?
Looks T3B. T3 is microscopic perivesical and T3B is macroscopic.
What is the most important finding in this?
There appears to be
Anybody?
There's no excretion of contrast from the left.
Left kidney is smaller in size compared to the right side, so that shows the chronicity of the problem. So you should have had it for a long.
The involvement of the left ureter is more than the right.
Yes. So
Okay. Next.
If the ureter is involved, what is the T?
at least T2.
What other investigation, once you have done the CT scan, what other investigation will you ask?
Liver function test,
Already
alkaline phosphatase.
Already done.
Already done.
Normal.
Looking at the mass, it is large size, broad based, and
extravascular extension. I want to do the chest CT. But you are not said about urine cytology. On CT, it is looking like large bladder tumor.
What is the indication for cytology?
Will you do
Cytology actually we do to rule out the presence of any high risk this thing, and CIS changes are associated CIS changes that there are not, or any high grade lesion present, and or
But in this case, there's already almost possibly extravascular extension. So how much role will
There is no indication.
And in terms of the word that we need to use is metastatic work. Metastatic work. And part of that, you're doing just any findings.
yes to be normal.
Expect. CT has been done and that.
So for the area guideline for doing the CT test in a CA bladder.
What sir is asking is, when will you do a CT test?
T3, T4 disease or more than T3 will do, sir. Otherwise, if patient is symptomatic or any symptoms based
findings in the
findings test X-ray.
Anything which is T2 plus, N1 plus, N0, N1 plus, Ethan,
Smokers.
Summarize the CT findings. Summarize this.
The CT findings are there is a broad based growth posterior wall of the bladder, also extending to the left and the right lateral wall of the bladder, encasing the bilateral vesicular junction, and there is left contracted kidney with the non contrast, and periocycle spread of the tumor, mostly T3B, and there is no metastasis.
So what will be the next step? Now that you have found this is a situation for you, what will you do?
I will confirm the diagnosis, histological diagnosis. After doing a metastatic workup, I will do a confirmation.
Why?
You are
What are the steps of it here?
sir. I will.
Don't tell the like points. Here we do what are these?
Sir, first I will do an cystourethropy, sir. I will examine the bladder.
Before the bi-manual examination of the bladder after emptying the bladder.
Pre-procedural and after procedure. After by manual examination, I will do an cystourethropy. I will examine the that part of the urethra and the bladder, and then characterize the mass, and then visit the tumors, both the superficial and deep biopsy to be taken and to be sent separately. And during so this is a mass at the ureteric orifice, sir. I would like to use an pure cutting current at the while dissecting at the near the orifice. Sir.
Will you give operator block?
Yes, sir. With the obturator block, spinal anesthesia with the obturator block, or GA with muscle paralyzing agents.
Want to see the prostate or not?
Sir, in cystourethropy, definitely I want to see the prostate. Sir, any associated CIS urethral prostatic urethral involvement also I would like to rule out. Sir.
Because for TURBT, if prostate is enlarged, there will be difficulty in the measuring the resectoscope. Yes. Is there an involvement of the prostatic urethral?
Management, sir. orthotopic, if you're planning to margins positive.
So EUA, examination anesthesia, was query, progress.
The steps of TRBT, proper anesthesia, examination anesthesia of the bladder, cystourethropy, assessment of the bladder neck, assessment of the mass, proper documentation of all the mass volume, all the number of tumors, resection, identify the ureteric orifice, see whether you can secure the ureteric orifice or not. And then at the completion of the surgery, make sure you've done another EUA before you come out and make sure diaphragm is good. Yeah, steps of TR. Have you understood why sir asked the question? Yeah. So, what are your comments, doctor? What are you going to do now?
It seems to be very high grade muscle invasive bladder cancer, along with that involvement of prostatic urethra as well. So we should proceed with radical cystectomy with ileal contusions.
You want same now the urologist quoting us invasive high grade with 30% microbacteria on plasmacytoid. This management is going to be the same.
So upfront RC we have to do, so very highly aggressive tumors of microbacterial variant. We usually do upfront RC and there is no role of neoadjuvant chemotherapy. Here we should give neoadjuvant chemotherapy, cisplatin based regimen.
What are the prerequisites for doing a neoadjuvant?
Sir, only cisplatin based only we can give, sir. Gemcitabine and cisplatin.
What are the prerequisites?
Sir, the GFR should be more than 60. Patient should have NYHA 2 or less than that. Peripheral neuropathy grade 2 or less than that. And audiometric also less than grade 2. EC 0.
In this case, I'm asking the question one more time. His creatinine is 1.4. He has bilateral HUN. And what do you want to do now? Creatinine is 1.4. Bilateral HUN. Left kidney is not functioning well. Smaller in size. Bladder full of tumor. You have done TRBT. Any human being can resect only 30% of the tumor that I'm seeing. Yeah. There is whole posterior wall is involved. And UOs are not secure. What will you do now? Will you give GC? Will you give cystectomy? What will you do?
I would prefer to go upfront for cystectomy.
Yes, cystectomy.
Cystectomy. What is the role of trimodal therapy in this? Okay. Now, patient's son is in US and he says, doctor, here everybody says, give me chemotherapy. Why are you not giving chemotherapy for this guy? Why not chemotherapy?
Solitary function in kidneys, sir. So already
But how do you know it's a solitary function? It's poorly excreting. Did we do a DDP or a DMSA to do a split renal function? Okay, we're finishing up. This session is finished.
That will delay the surgical management.
So what is important? Surgical management or chemotherapy?
Surgical management. Because neoadjuvant chemo we are giving.
So the cure of the patient is attained by the surgery.
Because T3 will have micrometastasis, so we should make every effort in order to optimize him for chemotherapy.
Then
But
you only said
then-
RCIC.
but then in this case, it seems
There might be presence of micrometastasis, so we should proceed with neoadjuvant chemotherapy first. So it will help.
How will you give neoadjuvant?
This case here.
This is a patient. I'm telling you, don't give theory. This is a patient.
In this patient, it's because of the compromised renal function and to borderline, we will avoid.
You yourself in your answer gave the clues. If somebody mentioned about GFR, how will you measure the GFR?
Cockroach God formula.
thing called DTPA. Yeah, widely available. You do a DTPA, tells the GFR of the split renal function, as well as the overall GFR. That will tell you whether the patient is eligible for a cisplatin or not. If the patient is not eligible for cisplatin, then there's no point giving neoadjuvant, correct? And if the GFR is borderline at 65, how will you optimize the GFR? Anybody? Only 5 minutes is there.
Try to divert the.
Would bilateral nephrostomy.
Yes.
Yeah, see whether the left kidney is a functioning component. Even if it's 20%, put a nephrostomy, optimize the renal function, give the neoadjuvant before proceeding with the treatment. Yeah. So the answer to the question is, when you have a patient with a muscle invasive bladder tumor and radiologically T3, you want to try and give neoadjuvant if possible, if we can optimize the function. How will you optimize the function? Assess the GFR, see the split renal function, see whether a diversion is required, and then give neoadjuvant if possible. But if the above criteria is not met, then the only choice we have is the upfront cystectomy. So, doctor, what are the complications of cystectomy?
Here we do a radical cystoprostatectomy, sir, with ileal conduit.
Here the prostatic urethra is involved.
Prostatic urethra is involved. So, yeah. So, you want to do a cystoprostatectomy with an ileal conduit.
Ileal conduit, okay.
Urethrectomy.
Urethrectomy also, sir, with urethrectomy. The complications, initial complications will be intra hemorrhage, sir. Bleeding from the lateral pedicle or the DVC, sir. There are troublesome bleeding. Post-op patient can have urinary leak or TVT, sir.
Intra-op complications. There may be involvement of the lower ureter. Bleeding.
Guys, I'm sure you have assisted system. What are the complications of system?
So, intra to be mainly hemorrhage and associated bowel injury. Most of rectal injury. Then post-operatively, there could be general operative complications that include DVT, thromboembolism, chest, pneumonia. Specific to the surgery, there will be possibility of positive margins in the ureters. There will be stricture, anastomotic stricture at the ureter site, leakage, bowel complications, including post-operative ileus intestinal obstruction due to any adhesions forming. There could be metabolic complications secondary to the use of ileus, which is hyperchloremic metabolic acid.
Is the most important and the deadliest complication in the system.
Bowel perforation.
You open the ball, you have perforated the ball yourself. IUI. Deadliest complication of radical cystectomy is not the IUI. Mortality of IUI is very 30%. Compared to DVT, which can happen in about 7%. Left ureteric stricture is 7 to 10%. And you know, when you tell some complications, divide it with operative, immediate post-operative, late post-operative, delayed complications. This is a very old MBBS teaching. So get into the habit of it.
Based on DTP findings, sir, based on DTP findings, if renal function less than 15% split renal function, then we can proceed ahead.
If you do a left nephrectomy, what diversion will you do?
sir.
Thank you so much.
I will request Professor to kindly greet our examiners with a bouquet of flowers, please. So, Raghavan, sir. Professor Thiruvaran. And Professor Raghavan.
Yes, we have selected 4 candidates at random, and we would like to ask them to come on stage, please. Dr. Javed from Chennai,
Dr. Javed from Medical College.
Dr. Dinesh from Stanley, Dr. Tanmay from
Tanmay.
and Dr. Rubina from
Yes. Yeah. This is, you will be having some pictures, each one of you. Okay, you can just take your seats. May I request the chairpersons for the next session, Professor Raghavan again. Professor K. Saravanan sir, Professor K. Saravanan sir, would you like to join the next session? And Professor Karunamurthy. Professor Raghavan, Professor Karunamurthy, as well as Professor K. Saravanan sir. Now, Raghavan, a very small change in the schedule. Just it's going a little monotonous, changing schedule a little. There will be some presentation pictures coming up. It's just a 2 minutes discussion. So one of you can, or all 3 of you can take care of it. First one, please. Maybe the sitting order you can select, Tanmay, you can discuss the first one. Yeah, Karuna sir, can you?
What is the finding there?
It's an IVU with the medialization of bile curator to be maiden waste deformity. And branches will be a retroperitoneal fibrosis, either Roman's disease or due to secondary cause.
Okay, medialization, okay. What will be the next finding usually?
The hydronephrosis.
Hydronephrosis or?
Hydrouretonephrosis up to the.
Oh. Is it classical here?
No, sir. The excretion is also hampered on the right knee. Or delay.
What is the treatment of choice?
Electrolysis.
Plain electrolysis, leave it.
And no mental rapid. Peritonealization of.
Are you able to see the whole ureter and the season from?
No, sir. There is either a deal on one of the sides, there might be a delayed excretion, which might be the reason.
Constant.
In case of deterioration of the renal function for temporary diversion, stenting will be useful, but not as a default.
In exact IVU terms, what is medialization? Tanmay, any idea? What is lateralization and what is medialization in exact IVU terms?
With relation to the tip of the transverse process of vertebra, if it encroaches onto the vertebral body, it will be called medialization, lateralization.
So medialization is once it crosses the pedicle and comes medially, it is medialization. Once it goes 1.5 centimeters lateral to the tip of the transverse process, that is lateralization. So when you go to the next slide, please. Dinesh from Stanley will be taking this. of 45-year-old female patient presented to us with a regular history of urinary tract infection and E. coli grown in culture. We did a cystoscopy that appeared to be a small growth kind of thing. And this was a histopathological picture. What is that you're seeing, Dinesh? There's an H&E stain.
Michaelis Getman bodies, probably Malakopic.
Okay, Karna sir, take over please.
What will be the symptoms usually they have?
ETT LUTS symptoms for sleep, and dysuria.
Would there be any hematuria, spare hematuria in these patients? How many percentage of the patients will have hematuria?
Very less than 5%.
Will you treat this patient?
Antibiotics. It's a chronic inflammatory condition, probably due to low-grade infections. Antibiotics.
Any other mode of investigation to prove that is Malakopic?
Histopathological examination.
The only thing.
Yeah.
Any differential diagnosis? Is it common in the diabetes? Recurrent urinary infection, what are them? One is Malakopic, what are the
Renal tuberculosis. Intestinal cystitis.
Jarthochronic fungal.
Can you describe what you're seeing there exactly? With that, we'll go to the next slide.
Basophilic cytoplasm.
Is it a basophilic cytoplasm or an eosinophilic cytoplasm or a clear cytoplasm? Look at that. A large cell with an eosinophilic cytoplasm. What do you call that cell as? No. What do you call it as? Von Hansemann cells, correct. And you're seeing a basophilic inclusion in iron and calcium, that is your Michaelis Getman body. So we'll move to the next slide. Here it is Javed. Just see and give your comment. Just see and give your comment. Raghavan sir? Yeah.
முதல்ல எனக்கு தெரியுமே. Yeah. People over radio opaque shadows present in the field. Pigment appearance. Huh? Multiple calcifications. Why is it sort of situated in the upper pelvis, not in the lower pelvis? The bladder is pushed. Is there a bladder there or what is? So what are these things found? Where are they found? So what is your thinking here? So multiple radio opaque shadow in a plain film. There are no contrasts in this study. So what is that likely to be there? Very smooth. All of them are very smooth. Isn't it? Stone where? Okay. Pouch. Huh?
The new bladder.
I do not know. I haven't operated Chegal Varela something.
Yeah, new bladder. Stone formation in the new bladder.
Stone formation in the neobladder. So it can be a stone formation in a bladder, be it the neobladder. If there is so much of elevation from the floor of the pelvis, it could be a large prostate there with a secondary bladder obstruction and a bladder full of stones. Alternatively, it could be a continent urinary diversion and the pouch is having stones. One of the two. Yeah, because I do not know. If there is a pouch, then there will be a central midline incision with clips and anything in there. I haven't seen any of the clips, incision, any of them. So I have to assume that this is a large prostate with the secondary bladder stones. I do not know whether
I think
streak of stones also present below what put that.
that is a prostatic stones, urethral stones.
that is the smaller part of the native bladder which is having stones there. There is a bigger one which is augmented bladder having stones there. I think the examiner has passed this exam.
Thank you, sir.
Because to be very honest, this was just a makeshift arrangement, just to break the monotony of the program. So even the examiners do not know what is being shown there. Thank you very much, Dr. Raghavan. The last slide, please. Saranan sir, please. Last slide.
Sir, it looks like a xanthogranulomatous pyelonephritis in view of the calculus which is present with the bare paw sign which is appreciated on the kidney, sir. But would like to also do a plane to see if the stone or presence of contrast as well, sir. But bare paw sign can be appreciated in the kidney, sir.
Any difference there?
GUTB RCC, cystic RCC.
The stone is very, the radiopaque shadow is very medium. You won't get assist so much.
So there is an X-ray of a classical stone with an XCPN. How many percentage of XCPNs you have without stone?
So 50% will be with stones, sir.
Around 70%, 50 to 70% with stones. Around 30% you can have without stones also. We are almost on time. We just got 3 more minutes to start the session. Before that, a very small request. Can we have a small photograph so that everybody is included with photograph? Professor Shashank, please.
All the participants.
All participants.